Everyone, thanks for joining. I'm Claire. I'm the head of partnerships at Sunfish, and today we're joined by Alease Barnes, who is a fantastic embryologist and does a lot of education with patients around the entire IVF process, answers questions, and we're specifically talking about embryo grading today. So, Alease, if you want to head to the next slide, just a couple of things for everyone listening. You're all on mute, so don't worry about that. If you have any questions throughout this, just put them in the chat. And then at the end, we're going to get to everyone's questions. So don't be shy. Anything that you want to know about embryo grading or embryo development or genetic testing as we go through, just drop it in the chat and we'll answer it at the end. Okay, great. And then just a little bit of how we're going to go through it. I'm here mostly for support for Elise, just to like chat with her, but she's the expert in this, so she's going to be walking us through the IVF process, the embryo development timeline. So for those days, day one, day two, day three, all the way up to day six, what that means, embryo grading, what those grade letters mean when they give you your embryo grades, and then PGT, so genetic testing. She'll walk us through that as well. And then how embryologists choose which embryo to transfer. Okay, so I'll intro myself really briefly and then I'll let Elise intro herself and take it away. But I'm Claire, I'm the head of partnerships at Sunfish. Previously, I actually was also an embryologist and an andrologist at Weill Cornell in New York. Fun fact, I was actually trained by the inventor of ICSI, which is the fertilization procedure where a sperm is injected into an egg. Elise will show you a video of that later, but learned that there. And then before that, after that, I was at Progeny and I led patient care for their largest accounts, which is a fertility benefits company. Elise?
Um, Happy to have you to chat with. And keep me accountable because I will just keep rambling. And so sometimes I need somebody to push me along.
I
Um,
we like to talk about this stuff, so it's okay.
I know it's hard. It's hard when I'm on a call with another embryologist. I'm like, we could just go on and on and on
I
forever.
know.
Like Claire said, I'm an embryologist. I've been in the field since 2017. Before that, I got my degree in genetics from NC State. And I have a really big passion for patient education. I started my platforms on Instagram and TikTok back in 2021 as a way to bring education about the IVF lab directly to patients and with a goal to empower them on their journey. And hopefully, I will be able to share some of that with you today. I know our topic is embryo grading, but we're really kind of going over a lot of different things. So,
Yeah, we're covering a
um,
lot for you guys today.
yeah, we're covering a good bit of things. So, um, like Claire said, leave those questions in the comments or leave the questions in the chat, and we will get to them at the end. Um, if there's one that comes up, Claire, like in the middle that you think is relevant, like please feel free to stop me. I'm super casual.
Okay.
So if there's one that seems relevant, like go for it. I'm happy to go down a rabbit hole. I always am.
Sounds good. I will man the chat. Okay.
All right, so we're jumping right on in. We're just going to start with a brief overview of the IVF process, really the stimulation process. Um, this is where we're doing daily injections of follicle stimulating hormone to have your ovaries mature more eggs. So typically that's daily injections. You're going into the clinic for monitoring to see your response to those medications. And then at some point you're taking a trigger shot to finalize that maturation process and start to release the eggs from the follicle. And then you are going in for an egg retrieval. One thing I like to point out with this is stimulation medication does not actually create more eggs. Your ovaries recruit a certain number every cycle, whether you're doing stimulation medications or it's a natural cycle. What the medication does is typically all those follicles that are recruited do not mature. Typically only one or two matures. And so you ovulate, excuse me, one or two eggs, typically one, unless you get, fraternal twins, that sort of thing. And the rest of them die off. With stimulation medication, we're actually forcing the ovaries to mature all of the eggs that were recruited instead of just one or two. So we can't create more eggs, but we can force your ovaries to mature all of the ones that were recruited. I think that's a big misconception there. Kind of a little diagram there. And then this is what the egg retrieval process looks like. So it is a vaginal ultrasound with a long needle that goes up into the ovaries to aspirate those follicles. And we will see a little video here. I'm also going to talk about insemination a little bit. So this middle video is actually a video from my personal egg retrieval.
I
I
love
froze my eggs back in October of last year. And so at a clinic that I work at. And so they were nice enough to film lots of really cool behind the scenes for me. I was able to see them get frozen, which was really cool too. And so this is actually, I'm asleep in this video, and that's me. Um, they use a vaginal ultrasound probe to, look at the ovaries, look at the follicles, and then there is a long needle that punctures the vaginal wall, and aspiration is used to, suction out the fluid from the ovary,
Yeah, and
from the
it's crazy.
follicle.
Like you guys, if you can see that dark circle right there, and you
Hmm.
see where it's going in and puncturing it, that's collapsing the follicle. So they're sucking out all of
Yeah.
the fluid, and hopefully
So
that
the needle
it
is
collects.
here. You can see that needle puncture right there. And the follicle will start to get smaller and smaller. You see it getting smaller and then it'll collapse. So that fluid is being sucked out and you can actually see the needle on ultrasound. Um, so that's kind of what's happening while you're asleep. Thankfully, you're asleep because it doesn't look that fun. I don't remember any of mine. It is a very short procedure, typically 20 or 30 minutes, depending on how many follicles a patient has. So it's not a very long procedure. You're usually in and out pretty quick. And prior to egg retrieval, because all of these follicles are so large, they're mature, there's lots of fluid. You feel kind of uncomfortable prior to the egg retrieval, but you'll also feel uncomfortable, unfortunately, a few days after the retrieval as well. I think a lot of people are like, oh my gosh, once the retrieval is over, I'm going to feel better. And it usually takes a couple days because once we puncture, or the physician, the embryologists do not perform egg retrievals, but we are involved. Once the physician punctures that follicle, it actually will fill back up with blood. So it takes a couple days for you to actually feel a little bit better. So after that retrieval, then we're starting to get into the lab. We are, stripping those eggs. If we're doing ICSI, we are, assessing them for their maturity, or we're doing conventional insemination. So on the left here is what we call conventional insemination, traditional IVF or IVF in general. That is where we keep these cells around the egg, which are called cumulus cells. They're actually needed for fertilization when we do this type of insemination. And we culture them with sperm. So you can actually see the sperm kind of swimming around in there. Any little dots moving, that's sperm. And they kind of sit in a drop of media, and the sperm still has to swim to the egg, get through those cells and into the egg. And then we have ICSI, which is on the right here. That's where we actually remove all of these cells. You can see the egg in there just faintly. We actually remove all those cells, and so it looks like this. And then we are injecting one sperm into one egg with a really small needle. This is often used for patients who have male factor infertility, and other reasons. So a lot of people do ICSI now. And it's very fun to do as an embryologist.
It is, but it's also very high pressure, but because
It is.
very
It is. It's
small little micro manipulator needles, but
exactly.
it is really fun to do. Honestly, I loved doing ICSI, so I feel you.
It was one of my favorites. And with this method, we're able to choose kind of the best looking sperm that we can. So patients that may have morphology issues or concerns, we're able to kind of bypass some of that by choosing sperm that looks the best.
Oh,
Yeah.
Elise, we already have a question, which I love. Thank you so much. Is there a significantly higher risk between ICSI versus regular insemination?
So, that's a great question. There's a risk for everything that we do. I do think there is more of a risk in terms of damaging an oocyte with ICSI compared to conventional insemination. The risk is low, but there is a risk. The risk is not zero. It's the same thing with some of the other procedures we'll talk about a little bit later in the webinar. Um, I have found that there are some patients whose eggs just don't tolerate injection very well. And so if we see a high number of degeneration, we may attribute it to egg quality. It could be technician related. There's so many variables that could cause degeneration during a procedure like ICSI. In general, though, we do see very similar success rates in terms of fertilization, blast development, and pregnancy rates. So I do think there are a lot of clinics who push ICSI because the risk of failed fertilization is lower. And so that's why a lot of clinics are like, we're going to do ICSI because you're already spending so much time and money to get to this point. There is a risk of failed fertilization with conventional insemination. So just because you've got a lot of eggs and you have motile sperm and the sperm quality is good, the sperm still has to bind to the egg and get through those cumulus cells and get into the egg. And there are sperm that don't have the mechanisms to do that, and it's very difficult to test for. So sometimes the test ends up being conventional inseminations, and patients will end up with failed fertilization because their sperm or their partner sperm doesn't have that ability to bind and penetrate the egg. So to avoid that, a lot of times, physicians will say, let's do ICSI and just avoid that altogether. So that's kind of that with ICSI. There is, but then again, there is that risk of potential damage there.
Yeah, that's a good
Okay.
point. So there's a risk on both sides essentially. So there's if you go with ICSI, very small risk of damaging an egg, highly unlikely, good fertilization rates. If you go with regular INSEM, good fertilization rates, but you do run the risk of there being no FERT or lower FERT than what was expected, especially if you have a slight male factor or a severe male factor. Your physician will most likely recommend ICSI in that case. So each one has its own risk. You just need to counsel with your
Mhm.
physician on what makes sense for your treatment plan based on your specific situation.
Exactly. And the risk of failed fertilization is also a low risk, but again, it's not zero.
Yeah.
So, you have to decide, like Claire said, which one is really the better fit for your case. That's a great question though.
Yeah, such a good question.
Okay, so once we have performed the insemination, regardless of which type, we're then on to embryo development. This is from my experience and from what patients have told me, the worst part of the process because it's so much waiting. You're not getting information, you're going in every other day for monitoring for 2 weeks, and then you have your egg retrieval, and then we tell you how many eggs you have, and then it's silent for a couple days. And you're
Cricket.
like, oh my gosh, I don't know what's happening. And some of that is because we don't either, because they're in the dish and we don't want to check them. We want to check them as little as possible. But essentially, this is what is happening um, during that time where you're not hearing from us. That first day, which is 17 to 19 hours after insemination, we are looking for fertilization. And typically, you're getting an update on this day. We are looking for two pronuclei, one from the egg, one from the sperm, and typically two polar bodies as well. They kind of shoot off polar bodies, and usually there's two, one from egg, one from sperm, and you'll get an update on how many fertilized. Also love this video.
That is a
Um,
beautiful
it's
blastocyst, by the way. Like that.
it's a great one. It's from the
Gorgeous.
Embryoscope. It's actually a training module, so
Okay, no
it
one
was
has seen
already on
that.
there. It's not a patient I worked with. It's just I use this for so many examples. But I love this because it tells you how many hours it's been in there, shows the development at that time, and it makes a beautiful blast. I love this video. So once we tell you that fertilization, we usually expect about 50% of fertilized eggs to make it to this blastocyst stage, which is day 5, 6, or 7. In between that time, we're seeing 2 cells, we're seeing 4 cells because each cell is splitting. Day 3, which is where some labs will do another visual check, and you may get an update on that day. We are looking for 6 to 10 cells because at this point, cells should be dividing evenly. And so we should see symmetrical cells. We should see them, you know, an even cleavage. So we don't want to see 7 cells or 9 cells. We want to see 8. They should be dividing about the same time. And so you may get an update on day 3. Now, usually when we see attrition, meaning not every egg is going to make a blastocyst, it most of the time happens between day 3 and day 5.
Mhm.
So oftentimes, most eggs that fertilize will cleave, majority of them, if not all. But we do see a lot of embryos that don't make it from this 8 cell stage to the blastocyst stage. And what we learned from research, which there's still so much research that needs to be done. We still don't know a lot of information because there's just so much to know. Um, from what we know, the egg's DNA drives development up until this stage. And at this stage is when the entire genome takes over, including the sperm's DNA. And so with that, it's a really big hurdle for the embryo to kind of jump over that combination of the DNA and continuing to drive development past that. And so we do see the biggest attrition between day 3 and day 5. So I think that's an important thing to talk about. Not every fertilized egg is going to, not every egg is going to be mature, meaning that we can't inject it. Not every fertilized egg is going to make a blastocyst, and not every blastocyst, unfortunately, is going to make a baby. And so we do see a really big attrition. And I know it's one of the least favorite parts of my job to tell people that yes, not every egg that we got made it to that stage, because every single one is precious, and we know that.
So really the number
Okay.
that everyone should be paying attention to is what they have on day 5 and 6, right? Like the blastocysts. Okay.
Yeah, so the blastocyst, I do think it's nice to know the general attrition. Just, if you've got 10 fertilized eggs, we can expect 4 or 5, 6 blasts, just to have kind of a general idea. But once we get to 5, 6, and 7 is, we're rolling at that point. Um, on day 5, 6, and 7, you're typically also getting an update from your lab. Some labs do an update every day. So day 5, day 6, and day 7. Some labs will do an update just at the end on day 7.
Perfect. Oh, we do have a question, Elise, but I don't know if it's a better question for a nurse, to be honest with you, but let's have a look.
I
I
will definitely just say I'm not sure.
Okay,
So I don't
fantastic.
know.
Okay, great. So this person said, thank you for your question, by the way. She said, I just had my first ultrasound for IVF cycle number 2. It showed a couple of hemorrhagic cysts 6 weeks after the first egg retrieval. Will that affect my second cycle of IVF? Thank you.
Um, from my experience, this is a question I would ask your nurse as well. There are some types of cysts that um, have to be resolved before you can start medication.
Hmm.
And there are some types of cysts that do not have an impact on your stimulation, week. And that usually depends on your hormone levels at baseline. So if it's a cyst that's like pushing out some hormones, that may be one that they say, let's wait for this to resolve before we start medication. But if it's not, throwing off hormones, they may say, we're good to go ahead. A hemorrhagic cyst, for my, again, I would consult your nurse and your physician on this one, but from my experience, is not one that typically hinders a stimulation protocol. It's also not usually one that a physician will drain at retrieval because they're usually filled with icky stuff. And so they don't want it to impact egg quality, because typically if there is an egg in that sort of fluid, it can damage. They're kind of toxic to the eggs. And so usually physicians will not drain those. Again, I am not a physician and this is not medical advice. I would definitely recommend talking to your physician and your nurses. But that has been my experience with hemorrhagic cysts. We usually call those chocolate, what is it? Chocolate cysts when you get them in the lab. It's rare though. Usually physicians don't drain them.
Such a good question. Okay, yeah, really good question. I'm in agreement with you. It's definitely something that you have to check with a physician because there are different types of cysts.
hmm hmm That's a good question though.
Yeah, it is.
All right, let's go on to the next one. There we go.
Oh, yay,
Okay,
embryo
embryo grading.
grading. Okay.
Now that we are, in the blastocyst stage of development, we are looking at blastocysts, we are giving them grades, and we are either transferring them, we are either biopsying them or freezing them or some combination. So with that means that we're grading the embryos, and we grade the embryos as a way to select embryos for transfer. So we give them a grade so that way when we go to choose them for transfer, we know which one was the best quality one when we looked at them, prior to freezing. So usually we are grading embryos on 3 things. The first is expansion, and that is the number. It's based on the zona and the blastocecal cavity. The second thing is the ICM, or inner cell mass. That is what becomes the fetus. That is graded based on a letter. And the last thing in the grading system is the trophectoderm. That is what becomes the placenta and is all the other cells surrounding the ICM. It's also graded on a letter scale. So 1 through 6, that is expansion. Typically, we see really most common is 4 through 5, 3, 4, 5, 6s. You'll rarely see a 1 and you'll rarely see a 2. I don't like to consider these really good or bad. It's more of a number of an indicator of maturity. So when the embryo grows, it starts to expand. It starts to push out on the shell that we call the zona pellucida. It's this kind of hazy ring you can see around the embryo. As the blastocele cavity and the blastocyst starts to get larger and larger, that zona will get thinner and thinner. And eventually it will hatch out. It will come out of that shell, which is what we need to have happen for it to implant into the uterus. So it's a good thing when it starts to do that. But we give the expansion a number based on how big this blastocele cavity is and how thin the zona is and whether it's coming out of the zona. So 3 is expanded, meaning the zona has started to thin, the blastocele cavity is larger. 4, meaning it's fully expanded, the zona is as thin as it's going to be, and the blastocele cavity is as large as it's going to be. 5 is when we start to see it hatching out of that zona. You may see there's a slide coming up where one is hatching. But you may have seen pictures of people's embryos where it almost looks like they're pinched in the middle, like a little infinity sign, or you may feel like it's splitting. It looks like it's splitting in half. That's actually the embryo starting to hatch out of the zona. Usually the hole that's created by the embryo is very, very small. So it like pinches a little bit and it just slowly oozes out. So you'll get that look where it's kind of pinched in the middle. That's a 5. And then when it's fully hatched, meaning the zona is completely gone, it's out of the shell completely, that is a 6. It's fully hatched. And like I said, 3s, 4s, and 5s are pretty common. You'll see 6s pretty regularly too. 1s and 2s, in my experience, are a little less common.
Yeah,
So
and
that's the expansion. That's the number.
would you say at least you want the number to be higher, right? You want it to be like a 3, 4, 5, 6, right? You don't want like a 1 to 2. Like that's like, oh, maybe
Yeah.
it's developing a little slowly, maybe not the best sign, but the higher the number is, you're like, okay, it's developing normally, it's on track.
Yeah, and usually a 1 or 2 is one, not that it's a bad thing, it's just we'll give it a little bit more time to continue to develop. The one thing I like people to keep in mind with all of these things in terms of grading is the timing matters. So if oftentimes labs are checking your blastocysts once, maybe twice a day. So if you're someone who, you've got 10 retrievals in a day and you're the last retrieval of the day, they may not be doing your ICSI until 4 p.m. But they may check your embryos at 8 o'clock in the morning. And so it's not really a full 5 days. And so take everything all of the grading with a grain of salt. The timing matters, the person doing it matters. There's a lot of subjectivity to all of the things we're talking about. So I don't like people to get too hung up on the grades. And in general, I don't really consider expansion kind of good or bad. I'm happy with 3s, 4s, 5s. 6s aren't my favorite just because they're not as fun to thaw. They're like super small and shriveled up, and it makes me nervous. And sometimes they can be subjected to more cryo damage because they don't have that zona to kind of protect them. So I lean into 3, 4s, and 5s being my favorites. But in general, a lot of the research shows very similar pregnancy rates between the expansion grades.
Great.
So the second letter in the grading system or the second thing in the grading system is the ICM. That's the inner cell mass. It's right here. That's what becomes the baby. It's graded A through C, where A is the best, C is the worst, just like in school. And what we want to see for a nice ICM is a good size. We want it to be nice and compacted. This is a nice ICM. Sometimes ICMs can be kind of flattened out or they can spread out across the embryo. We want to see it nice and rounded, and we don't want to see it releasing a lot of dead cells. So the embryo is actually smart enough to say, this cell is abnormal, I don't like it, and it will throw it out and it will not be incorporated in the embryo. We don't want to see a lot of that because it makes us concerned. Why is it throwing off so many cells? Is it trying to fix something that's wrong? So we don't want to see a lot of that. And like I said, the nicer the ICM, the higher the grade we typically give it. A is the best, C is the worst. And that's pretty much all I have on ICM. You have anything to add to that, Claire?
No, that's perfect.
All right, so that's the second letter. The third and last thing we're looking at when we're grading embryos is the trophectoderm. That is all of the other cells in the embryo, not including the zona. We're not looking at the zona at this point. We're just looking at all the cells. And really, we're looking at the cells back here too. But these are the easiest to see, which is why I kind of highlighted them there. That becomes the placenta. That is also where we remove cells when we are performing embryo biopsy for PGT, which we'll talk about, I believe, in the next slide or the next couple slides. Again, that is graded A through C. And for a nice trifectoderm, we are looking for kind of a cobblestone look. If you've ever seen a cobblestone street, that's what we're looking for. We want to see lots of cells. We don't want to see bald spots where the embryo hasn't quite grown enough cells to cover the entire zona. Um, we again don't want to see the embryo kicking out a lot of degenerated or dead cells. We don't want to see too much stretching. And usually with the trifectoderm, remember all of this is 3D. So this is a 2D image of a 3D object. So when we're grading, we actually look at the bottom of the embryo, which right now is blurry, and we look at the top as well. So we're looking through the whole thing to kind of get a full picture of the embryo because sometimes in some planes they look really good and then you'll zoom a little or you'll change the focus a little bit and you're like, oh, actually it's bald up here, like, and you don't realize it. So that's another reason why I don't grade embryos from people's pictures because it's
Oh,
very
good point.
difficult. I get that request a lot, and it's not something I'm comfortable with because of it's a 2D picture of something
Right, you
totally.
can't see the whole thing. You're like, well, I don't know. Like this cross section looks good, but we need to
Mhm.
see the whole thing. That makes sense. And Elise, what would be an example then of a good embryo grade?
Yeah, so once we have all of those things together, we get three things. So like a 4AA, 2BB, 6BC, and they kind of all come together to make that grade. And really, each clinic is slightly different on what they consider good and bad, but I always like to go with the Gardner scale and SART grading. SART considers a good embryo AAs, so an A trifectoderm, or excuse me, A trifectoderm, A ICM, oh my gosh, an A trifectoderm, an AB, so slightly lower um, trifectoderm. And then some will consider a BA also good quality. Some people will consider it fair because the ICM is a B and they value the ICM more than they do trifectoderm. That's very much a personal lab preference thing. Fair is typically considered BB. Again, BA is kind of dependent. And then BC is also one that I see. Some people consider that fair and some people consider that poor because of the C. Usually, poor quality embryos are considered CCs, CBs, and anything lower than that. It's rare that an embryologist will free something with a D grade, which is why we put A through C here. Usually anything below a C is not something that's being frozen. It either doesn't have an ICM at all, it doesn't have a trifectoderm at all, it's dying, or some other combination of not great things. And we typically don't freeze those.
Yeah. Oh, Elise, we just got a really good question. So
Oh,
someone
good.
said, it seems like embryo grading is somewhat subjective. Do you ever get second opinions if you're on the cusp of a certain grade?
Yes, all the time. I'm sure Claire has too. So if I am grading it, oh my gosh, we're gonna get into all of this. That's such a great question. Grading it, and I think is it the next one? No. I'm actually gonna go to this one first. Um, uh, I'm actually gonna no, we'll talk about the subjectivity. There's a couple things I like people to know about embryo grading. The first one is very subjective. So the goal is to have all of the embryologists in your clinic grading similarly in terms of strictness. That doesn't always happen. I have been told at some clinics that I'm too strict, and at other clinics I'm too lenient. So it really much depends. When you start to look at between clinic to clinic is really where we see the largest variation in subjectivity. It also can very much depend on the other embryos in the dish, which I don't think people think about. So if I'm looking at an embryo, the very first embryo in a patient's dish, and I'm like, this is beautiful. I'm grading this in AA. And then I look at the next embryo and I'm like, actually, this one is nicer than the other one. I'm going to grade the first one in a B because I like this one more. And if I'm coming back to this in a month and I want to, thaw the best looking one, I actually want to make sure I choose this one and not the one that I just saw. But if the next one is really ugly, you'd probably keep the grade of an AA for the first one. But does that mean that the first one has a lower chance of pregnancy? No, it's the same embryo. It's just we've graded it slightly different based on what else we're seeing in the dish, potentially what patient we saw before the patient we're looking at now, or the patient after. So those are really things to consider, which is why I say grading is so subjective. At the end of the day, I like patients to keep in mind that if it's something that we froze, we think it's worth transferring. We don't want to waste your time freezing stuff that's not going to make a baby. We don't want to waste our own time freezing things that we don't think are going to make a baby. And so in general, if we're freezing it, we think it's worth transferring. But it is very, very subjective. Even between embryologists, there are many times where I'm like, this one is borderline for me. And I will definitely call over other embryologists. I'm like, hey, can you take a look at this? What do you think? Do you think it's worth keeping? Especially in those cases where maybe a patient only has one embryo and it's not the best quality, or there's other circumstances where it's like, do we freeze this one? Do we not? And there are times where calls are close and it's like, well, I think we should do this, and someone else may disagree. And we do have a conversation about it, and come to some agreement. And I'm sure, Claire, you've had similar experiences.
Yeah, typically from what I've seen, if an embryologist is not sure, but usually they're pretty sure about their grading. If they're not sure, they definitely tap another embryologist to provide a second opinion. And there's so that
Mhm.
there's at least a consensus. So one person will write down their grade, the other person will say what their grade is, and they'll compare to see what's similar and they work it out. So yes, they do get second, everyone gets second opinions typically.
I mean, I do it all the time. If I'm not sure, two heads are definitely better than one in these instances, and I'm like, I want someone else's opinion. And especially if it's someone who's worked at that clinic longer than I have, because there are embryologists who have worked at the same clinic for 30 years. And they know what the physicians are looking for, and they're very confident in their grading, and their strictness is right on par with it, with what we're looking for. And so those are the ones that you're like, hey, can I get the most senior person over here to check this out with me? They
Exactly.
know a lot more than I do. They've seen millions more embryos than I have. Let's have them take a look. So that's a great question. We definitely collaborate. I'm a big collaborator in the lab. You kind of have to be.
Yeah. Oh, you definitely have to be. And a lot of times, like the lab director can be the tiebreaker. But oh, another question, which you did already sort of answer, but I'll let you answer it again more directly. Is there a likelihood or percentage of implantation success based on the embryo grade?
Yeah, so we're going to touch on that a little bit more in another slide. And so the research does show some slight correlation between embryo grade and pregnancy rates, but again, because grading is so subjective, we cannot say that the 4A embryo is going to make a baby and the 4CC embryo or BC embryo is not. And that's because, like I mentioned before, I may say, I think this embryo is an AA. And Claire may say, you know what? Actually, I think it's an AB. With some of the charts, the AB would have a slightly lower pregnancy rate than the AA. But we know it doesn't because it's the same embryo. We just graded it slightly different. So, all of that kind of comes into play when we're talking about pregnancy rates and embryo grade. There is a slight, like I said, there is a slight correlation, but there is a reason why we choose the best quality embryo, right? Or we
Right.
wouldn't
Like
grade
there is
animals.
a correlation. Like definitely a better looking embryo versus an embryo that really looks like it's struggling. There's a higher chance of success with the better looking embryo. But then there are other things that Elise takes into account, like if there's genetic testing results and things like
hmm
that as well.
And that honestly, you'd be surprised how many times I'm like, oh yeah, this A is going to make a baby and it doesn't.
Yeah.
But that patient's BC embryo does. And so the grade is there to help us make a selection when we're choosing an embryo for transfer, but it doesn't guarantee anything. And there are many times when the patient's worst embryo is the one that makes the baby. And it's always surprising, but it happens a lot, where we're like, okay, this is just an average grade. We've already, transferred their best looking one. We're going to go for the next best, and that's the one that makes the baby. So there's a lot of other factors involved. And when we get into PGT, which is next, we can't say based on looking at it which ones are going to be genetically normal. And grade somewhat plays a factor in that, but it's not enough for us to say again that this AA embryo is going to be normal and the BC is not, because it happens all the time where we're like, yeah, this one's going to be normal and it's not, and the BC is, and we're like, what? So it is very subjective. There's a lot of factors into it that play into it. And at the end of the day, I just like people to know that if we froze it, it's worth transferring. Okay, let's get into PGT, because I do think I'm going to touch on it briefly. I'm not going to go too deep into it because there's a lot of nuance to PGT testing, and I do think it's a great conversation to have with the genetic counselor if you're considering PGT testing. I always think people should see a genetic counselor before they decide not after. Most of the time, you're talking to a genetic counselor after you've already done the PGT testing because you're talking about the report. But I think it's so important to talk to one prior to testing to really understand what the testing is telling us. Okay, so in this video, this is a hatching embryo. This would be a 5. There are some cells that are coming out of the zona there. And this is what it looks like when we perform embryo biopsy in the lab. So we're using a laser to strike the cells between, at the cell junctions between the cells, and we're removing 5 to 7 cells from the part of the embryo that becomes the placenta. The embryo never leaves the lab. And I think that's a big misconception. The embryo is frozen and stays in the lab. The part that goes off for testing are the cells that we remove. So the embryo is always with us. The cells just get sent out. We put them in really tiny tubes and we send the cells out for testing. So PGT stands for pre-implantation genetic testing, and the most common form is aneuploidy. That's for chromosomal abnormalities that happen typically during the growth of the embryo or due to egg or sperm, not something that is passed from parent to child. So if you have started your journey or will be starting your journey soon, usually you're asked very early in the beginning, do you want to do carrier testing? And that is different than PGT testing. Carrier screening, excuse me, not testing, carrier screening, screens you and your partner for inherited genetic disorders. Something that you carry, you and your partner both carry that can be passed on to a child. Things like sickle cell, cystic fibrosis, SMA, and some Huntington's disease. There's like, I mean, they test for like 500 now. There's so many. But if you and your partner, typically, depending on the type of disorder, are a carrier of the same genetic disorder, we are doing something called PGTM for monogenic disorders. Those are things that you and your partner both carry that you could pass down to a child. Aneuploidy screening, which is the most common, are things like Down syndrome, trisomy 21, trisomy 18, sex chromosomes disorders, not something that you have passed down to, that you could pass down to your child, something that happens during development of the egg, sperm, or embryo. We can also test for things like structural rearrangements, so balanced translocations, inversions. That is determined, you are determined to have a structural rearrangement if you do a karyotype testing. So these two in the middle here are things that are only tested for if you have a pre-existing reason to test for them, versus aneuploidy is used typically when patients are a little bit older, our eggs are not as good as separating chromosomes, or sperm is not, sperm plays a factor in there as well. And we're testing for things that are not passed down, just things that kind of happen with age. This
Yeah.
last one, polygenic disorders, those are genetic disorders that we can say that your embryo has a potential risk of developing, but there are multiple genes involved. So things like diabetes, heart disease, and for patients who may have a family history of, some of these disorders, polygenic testing may be something you're interested in. This is a much less common test. Typically, PGTA is the most common, but there are patients who have an interest in testing for those things. So typically, it will tell you whether your embryo has a higher likelihood than the general population to develop a disorder, but it can't say for sure that your child will. So just because you have a predisposition to getting diabetes, your environment plays a really big role in whether you actually develop diabetes, type 2 diabetes. So some things to keep in mind. 100% recommend talking to a genetic counselor. They're absolutely fantastic. They are such an important part of the care team, and they can really break this stuff down. There are a lot of limitations to PGT testing. It is not a perfect test. The biggest one being we are taking cells from the part of the embryo that's going to become the placenta. How representative are those cells to the part of the embryo that becomes a baby? We don't touch that part because we don't want to. We don't want to damage it as a part that becomes a baby. So we have to, keep those things in mind. We're taking 5 to 7 cells from an embryo that has 100 to 150. All the testing platforms are different. So, iGenomics versus Cooper versus all the other PGT testing companies use different platforms, use different thresholds in determining what's normal and what's abnormal. So all of those things are really important and come into play when we're talking about PGT. And that's where I'm going to leave PGT because I could just keep going. There's so much about PGT.
Yeah, yeah, but to keep it simple, when people think about PGT, most often they're thinking about PGTA, which is assessing for aneuploidies. That's that first bullet point. And what aneuploidy actually means is an incorrect number of chromosomes in a cell. So if you do PGT, there are usually three different results. You can have a euploid embryo, which means we tested, it looks like there were the correct number of chromosomes, so most likely to implant. Then there's aneuploid, which means the cell had an incorrect number of chromosomes, so probably not likely to implant, probably abnormal as an embryo. And then there's mosaic, which means some of the cells had a normal number of chromosomes, and then some of the cells didn't. It's kind of a question mark. Should we transfer it? It might work, it might not.
Yeah, no, that's a great breakdown. That's a great breakdown. We are looking at the chromosomes. Yeah, yeah.
Oh, and
PGT.
we have a
You got
question.
a question?
Yes.
Awesome.
Okay. We had a few embryos come back from PGT testing indicating the biopsy size was not large enough to test. What is the risk with thawing and redoing the biopsy? Will there be enough cells left? That's a good question.
That's a really great question. So, another potential limitation of PGT. We don't always get a reading, and it can be due to a lot of factors. It can be due to the quality of the cells and the quality of the DNA in those cells. It can be due to the sensitivity of the testing platform. It can be due to the embryologist and how well they perform the procedure and rinse the cells. But there oftentimes is an option to thaw the embryo, rebiopsy it, and send it off for testing a second time. I think this is a great conversation to have with your physician. Some of the things that they may take into consideration is other embryos in the cohort. Oftentimes, physicians will say, well, we've got 4 or 5 euploid embryos to transfer. Why don't we go ahead and transfer this first and then come back to this one if we feel like we need to do that? The other thing they take into consideration is the embryo grade. So, oftentimes, if an embryo is poor quality, they may say, you know what, I don't think this embryo is good enough quality to thaw, biopsy a second time and refreeze. Everything that we do is a risk. We've said that before. And everything that we do, um, um, I was just going to say, stresses out the embryo. That's what I was going for. There's stress to things that we're doing. We are removing cells from the embryo, which research is showing us we're still having successful pregnancies, just as we do with embryos that are not biopsied. So in general, the risk is very low, but it's not zero. And the more we stress out an embryo, the more potential it is for it to not survive a subsequent thaw or subsequent biopsy. And so all of those things are important to take into consideration. We are considering that testing. Oftentimes, if we have biopsied an embryo that may be borderline, we say, I really want to give this patient an extra embryo. I think, I want to do the biopsy. I think it's good enough to biopsy, but I don't know if I feel confident in the quality of cells, or that if this were to come back inconclusive or no DNA, that I would feel comfortable biopsying it a second time. Oftentimes we will put a note, like I do that. I'll put in the comments, not eligible for rebiopsy. I don't think this embryo is a good enough quality to biopsy a second time. I'm going to write that in the comments. And that's not every embryo. It's rare that I do that. It's really one of those borderline calls where I'm calling someone over and I'm like, what do you think? What should I do here? I want to biopsy it now, but I don't think it's worth doing a second time if it doesn't come back. And so we'll make that note. Oftentimes, if your embryo is a good quality, um, um, and it may be the only embryo you have, or you only have a couple, oftentimes the risk is very low. If you've got an AB quality, BB quality embryo that you want to thaw, biopsy, and refreeze, oftentimes they go very smoothly. I just think it's important to consider all those things and talk to your doctor about them, and weigh the kind of pros and cons and see what's best for you.
Yeah, that's a good one. Yeah, because I guess the option is either to try and rebiopsy or to transfer it without testing, like transfer blind essentially, or maybe just not,
Exactly.
you don't want to, basically.
Exactly. It depends on what the patient wants to do, but essentially in those cases, just because it did not come back with a result, that does not mean that it's abnormal. So it really has the same probability of being normal, abnormal, mosaic as all of the other embryos. We essentially consider embryos that have no DNA detected or no result as an embryo that we did not test at all. So it doesn't mean that it has an increased likelihood of being abnormal. We treat it just like an embryo that wasn't tested at all. And so patients will either decide to biopsy them again, they'll decide to transfer them as if it's untested, or they may decide to discard or, a myriad of other things depending on their family vision and what they've done previously in terms of treatment. So, yeah, that's a good point. Essentially, you'd be transferring it as if it was untested.
Yeah. Yeah. Thanks, Elise. Okay.
Yeah. All right. I know we're a little over time. I knew this was gonna happen. I'm so chatty. I'm
But we
sorry.
knew, we talked about it. We were like, we are going to get so into this topic. Like, we're going to stay.
Yeah, because there's just so many good things to talk about. All right. So, how do we choose an embryo for transfer? This is another really common question that I get along with embryo grading. There's so many things that we choose, we use in making that decision, and some of them, and AI is one of them. I didn't list that here, but we can get into that. Typically, the first thing we're looking at is PGT results. We want to select an embryo that is PGT normal, PGT euploid, if the patient has done PGT testing. Not everyone does PGT testing, but if they've done the testing, that's why they did it. So we select one that is euploid or has the correct number of chromosomes. And so that's usually the first thing we look at. We'll omit the ones that are aneuploid and start with the euploid ones. Then we typically look at day of development. So, embryos can be frozen and biopsied on day 5, day 6, or day 7. Again, it's how fast the embryo make it to the blastocyst stage. We typically choose a day 5 embryo over a day 6 and or day 7. I do think things are changing in terms of research when it comes to pregnancy rates between day 5 and day 6 and day 7. So historically, day 5 embryos had much higher pregnancy rates than day 6 and day 7. I think because of the PGT testing, day 5 and day 6 embryos are having similar pregnancy rates, and it's not because of the PGT results. It's because of why we're biopsying. Oftentimes, if a patient is not doing PGT testing, we may freeze an embryo a little bit early in expansion grade, a little bit earlier in development on day 5. If we are doing PGT testing, meaning we have to do a biopsy, a lot of labs are saying, you know what, this is a blastocyst. This is a blastocyst we would freeze. This is a blastocyst we would transfer. But to biopsy, I really want to see it a little bit more mature. I want to see a little bit more cells. And so they push the biopsy to day 6 exclusively for the purpose of doing biopsy. And so because of that, it was a blastocyst on day 5. We pushed it really only to do the biopsy. And so our pregnancy rates are much more similar between day 5 and day 6 than they used to be prior to PGT testing. Now we do see a significant drop off between day 6 and day 7. That slow development, those embryos, we do see them more likely to be abnormal. We do see lower pregnancy rates with those day 7. So usually day 7s are the very last ones that we will transfer. And like I said, day 6 and day 7 pregnancy rates are very similar right now with what we've been seeing in research, but we still choose the day 5s. We still choose the day 5s first because it's ingrained in us, and we still say, hey, it got there early, it got there on time, we're doing the day 5. I just don't want to discourage any of y'all who are listening that have only day 6 embryos and think that they're bad. Oftentimes we are pushing them on purpose for the reason of doing biopsy. And so they are still worth transferring. Like I said, we froze them. We think they're worth transferring, but usually we are choosing day of development after PGT results. Then, we are looking at the embryo grade. So we've got a normal embryo, we've got a day 5, we've got 5 or 6 to choose from. Hopefully, we got lots to choose from. Then we're choosing based on embryo grade. We want to choose the best looking grade because we still see that slight correlation between embryo grade and pregnancy rate. So we're choosing the best one. And then we have other kind of factors that may not necessarily be scientifically related. And some of them are. Some of them, we have a genetic disorder that is more prevalent in female embryos. So we're going to choose a male because the likelihood of them having that disorder is lower because it's male. Patients want, family balancing, or they have different family building goals. And so that comes into play as well when we're choosing an embryo for transfer. I think that's everything. Anything to add to that, Claire?
No, that point about the day of development was really interesting because, yeah, historically, day 5 and day 6, day 5 tends to be higher, but just for everyone like to know, day 6 embryos actually have really good success rates too. It's not
They
like
do.
some drastic difference where you're like,
Hmm.
what just happened?
We're
Um,
talking about a couple percent here.
yeah, similarly, great success rates day 5 and day 6. But that's a good point that if you have some day 6 embryos, but they went for biopsy, they may technically have been a day 5 embryo. It's just that they wanted to see it progress a little bit more before they biopsied it, probably for like the safety of the embryo, to be honest with you.
Exactly. That's exactly what it is. The safety of the embryo. We want to make sure it's got enough cells. And so we pushed it specifically for that reason. Yep. Yep.
Love that.
Exactly.
So
Exactly.
interesting because that's like information I had not heard yet. Because like PGT, like I feel
Oh, okay.
like, yeah, like the studies I feel like have are still like back in my day, like it was still called PGS, like and then
I
well,
know.
and then it turned to PGTA, and I think I was like, wow, I'm writing one of the first papers I feel like where we use the term PGTA, and it's so funny.
Some people still say PGTS, like
Do
some of the
they?
old school, like original embryologists. And they'll like correct them. I mean PGT. They're like PGS, just kidding, PGT. It's like so ingrained in your mind. And it's
Oh,
interesting to see where it will be in 5 years and 10 years. We could be calling it something completely different by
I
then. Who
know, and
knows?
it's a great tool for people who want to use it, but like you said, it's not you know, the end all be all. But
And it's not for everyone. I do think it's important to talk to your physician about what's best for you. There's so many factors involved, age and financial situation and family goals and personal beliefs. There's so many things involved with it. And so I don't like to push specific treatments because it's really all dependent on your provider. And one of my big reasons for creating my platform was to give patients the education to be able to have these conversations with their provider. If you don't have a base knowledge of what PGT is or what the point of it is or how it works, it's really difficult to have a conversation with your provider about whether it's a good fit for you if you're not understanding what it is to begin with. So that was my goal. Like I want you to be able to have an informed decision with your provider about your patient care. And so I hope this helps contribute to that. I think we got one more slide. Success rates. We've talked about success rates kind of all throughout this at this point. But we've kind of gone over these things. Grading is subjective. If you're looking at charts online, excuse me, that talk to you about, an AA has, a 57% chance of pregnancy, but an AB has a 54% chance of pregnancy. It's all the grading on that is subjective. I could have graded an AA, but if Claire was beside me and grabbed that patient before I did, she could have, graded it something completely different. But the embryo has the same chance of pregnancy because it's the same embryo. We've just graded it something different. There are many factors that play into success rates, embryo quality, embryo genetic makeup, even with a PGT euploid embryo we can see failed fertilization, or not failed fertilization, failed implantation, because PGT cannot test for everything. It's testing for large chromosomal abnormalities. It's not testing on a gene level. It can, miss small genetic abnormalities. Um, a good quality embryo does not guarantee success. We've talked about this before. It does not guarantee genetic normalcy either. So basically, we're telling you we don't know. I'm just kidding. We know some, we don't know everything. Um, Again, I've hit this so many times. Embryologists typically only freeze embryos we think are worth transferring. We don't want to waste your time, your money. We don't want to waste our time. We want to freeze things that we think are worth transferring for you. And again, this day 5, day 6, or day 7, does it play a role? We know it plays some sort of role, but how significant the role is very much depends on a lot of factors. In general, we are still choosing a day 5 over a day 6. We really see similar pregnancy rates here, and we see a larger drop off when we get to day 7. I think that's everything. I'm sorry I've kept you guys so long. This is my information, my Instagram, my TikTok, my Facebook, my website. I should have put my email up here. Feel free to reach out to me. I answer DMs. I cannot give you medical advice. I'm not a provider. I will also not grade embryos over DM. But if you have any questions or just want a little support, I love following y'all on your journeys. And I have patients who update me on Instagram DMs, and I love it. I think it's so sweet that y'all consider me in sharing your journey. Please feel free to reach out to me. I do answer DMs. Sometimes it takes me a little bit because I'm in the lab and it takes me a couple days to get back, but I usually do. So feel free to reach out. I'm very reachable.
Awesome. Thank you, Elise, so much. This was so much fun. And thank you, everyone, for joining and for your questions. If you have any questions specific for your care team at Sunfish, just email us at care@joinsunfish.com. But go follow Elise. I love her page and her channel. It's so good. So if you have any follow-up questions for us, we're here. If you have
Yeah.
another topic you want us to cover, happy to get someone else on to have them cover something too. Elise might be connecting us with a couple of people for some future topics.
Yes, I've
But
got some good people to hopefully have you guys learn from.
yeah. So thanks everyone for joining. Have a good day.
Bye.